up in the meantime. So glad that people are all here. Want to introduce Professor Zanos. You can do the more thorough introduction. I'll just tell you what I know, which is not enough, because he's done many amazing things. It's a really interesting history, too, because like healthcare, AI stuff is not what you're training in origin stories. I hope it's tell us some of your superhero origin story. I met Professor Zanos at the CID, which is a Clinical Informatics and Digital Health NIH study section. So when you submit R1 grants and this kind of thing, if you submit from the subjects we study, you very likely could be reviewed by this study section. And one of the benefits of these study sections, you're supposed to go in person, so you can go out and have dinner with people, and not just a Zoom meeting that goes on for 8 hours, and strike up surprising conversations. But Professor Zanos has a lot of very sharp perspective, has a lot of good insight, very thoughtful review and scientific perspective, and all of that was there, but also he's just a very fun, dynamic guy. A lot of great stories to share about what it takes to survive and hopefully thrive in this environment. And I particularly want to pick on, I don't know if you're going to come today or I'm going to pick it on you over dinner, was you were doing some things for the hospital system too.
Yeah, I'll go over
and to you it was like incidental, like, I don't know, sure, whatever. It's some simple analytics thing. It meant almost nothing to you, but it turned out to have some hugely outsized impact clinically that I think even you didn't realize was the case until after the fact.
when we first started. Yeah, I'll go over some of the widgets.
And I thought that was very insightful too, to have those experiences. We often don't even realize where the connections are more impactful than we would expect from one perspective. With that in mind, maybe Dr. Zanos, maybe for a couple of, just tell us about yourself. Before we dive in, and we'll dive in maybe the next 2 or 3 minutes, just tell us about yourself, where you were born, where you grew up, how did you end up where you are?
Yeah, sure. Well, first of all, thank you for coming. Really happy to be here. Really happy to escape the New York cold and enjoy this beautiful weather. I miss California this type of year. So I was born in Greece. And I grew up there. My first degree was at the university there in the second largest city of the country, in Thessaloniki. The university is called the Aristotle University, which for a lot of my American friends was very funny that we named the university after Aristotle, but for us it was kind of like, okay. And my first degree was in electrical and computer engineering, so pretty straightforward. Computer engineering back in the day, no machine learning or AI, really dating myself a bit. But then I spent the summer at the University of Washington doing a summer internship, and that really made me realize that I really wanted to come to the States and to pursue a graduate degree of some sort. So I applied for PhDs. I eventually joined University of Southern California, the Biomedical Engineering department. And back then, my focus was mainly on computational neuroscience. So I was really interested in studying the brain, but from the angle of an engineer, because I thought there was a lot that I could contribute to the neuroscience field from a bit more data analytical approaches like signal processing and systems identification, which we I guess now call machine learning. So my PhD was on nonlinear multi-input, multi-output Volterra models, which is scalar expansions. It's convolutional model that precedes, I guess, the more modern convolutional neural networks. And that was applied in recordings from the hippocampus of rats. After I finished my PhD, I went to McGill, to the Montreal Neurological Institute. I wanted to get my hands a bit more dirty on the neurophysiology side, so I started doing primate neurophysiology, which is the hardest if anyone of you have worked on neurophysiology. Working with primates is very interesting, but also quite hard. So I started my postdoc there doing computational neuroscience, but looking at the visual system and how our visual system processes information, especially around eye movements. So I used my kind of like computational skills but I also learned how to implant electrode arrays in brains of monkeys. I did the surgeries, I did the trainings, all that. And then when the time came to start my own lab, when I started looking for positions, whenever I was proposing to start a primate lab, that would rule out 90% of the places that I could go, because private labs are not very common in a lot of universities, and they become, for a lot of different reasons, even more rare. So I decided to pivot a bit. I eventually ended up in New York, joined the Feinstein Institutes for Medical Research and Northwell Health. For those of you that don't know, Northwell Health, it's the largest health system now in the Northeast. It used to be in New York State, but now it's all over Northeast because we've acquired also one of the larger systems in Connecticut. It's 28 hospitals, it's more than 1,000 outpatient clinics, very large footprint, really large organization, more than 110,000 employees. And the Feinstein is the research arm of Northwell. So they have basic science there, people doing molecular medicine research, translational research. So I started the Neuron Neuroscience Lab, kind of like focusing again on more peripheral neuroscience and applications of data science and data analytic tools on those types of electrode recordings. But pretty quickly I realized that Northwell has an immense amount of clinical data, and surprisingly, no one to look at, to analyze them in a more sophisticated way, especially from the research standpoint. So I started the lab in 2016. By 2018, we were already working on some clinical ML projects. And then shortly after COVID, where that started gearing up a lot because I guess the leadership of Northwell started understanding that there is value in this work, we created a division of health AI. And the reason why I created the division instead of just keeping the lab is because we started getting more and more requests, and I'm going to get into some of these, from the health system on things that it was not part of our general research strategy or research programs, right? More operational asks, more one-offs. And I told them that, I mean, this is not necessarily something that it will give me more papers or grants. I would love to help, but you guys will need to support those additional FTEs. So that's why we created the division. We kept the lab anyway. And yeah, I mean, since then we've been working a lot on deterioration prediction models, some operational tools, a lot of different types of projects and applications of ML mainly. But yeah, I'm going to go over some of these. Hopefully some of these are interesting, and yeah, we can talk more about it.
Awesome, fantastic. We also have dozens of people online as well. Why don't we go ahead and dive in, and I'm sure it'll spur some discussion.
Okay, so as I said first, I always like to start with like the people that actually do the work at this point. I'm mostly replying to emails and reviewing grants. So the Division of Health AI is right now around 18 different people that have mostly engineering background, although we have a lot of MDs, and those are our MVPs because they are bringing in a lot of clinical experience and expertise, and they are there from the get-go in all of these different projects to kind of like guide us on making sure that we're not doing something that's completely useless from the clinical side. And of course, we have a lot of collaborators that are mostly clinicians and clinician scientists. And our division is funded mostly by NIH, but we also have some funding from industry as well. We work and collaborate with several different companies. So we have, at this point, and I hope this is not going to expand even more, 5 different verticals, and these are capturing broadly the different types of projects that the people at the division are working on. So we have the preclinical AI part, which is mainly what my lab was doing when we first started. It's recordings from mice from the peripheral nerves and relating that to disease states. I'm not going to go over that part, but I will talk about the next one, which is the autonomic nervous system and applications of AI ML there, where we're trying to develop algorithms that use non-invasively acquired physiological signals to diagnose disease presence and severity, and then predict the treatment efficacy as well. We've dived into the anatomical AI applications the past 3.5 years because we got a relatively large NIH funding for this, and that became another thrust of the division, where we're analyzing multiple different modalities of imaging, microscopy, CT, micro-CT, and developing in silico models of peripheral nerves, and specific nerve, the vagus nerve, and I'm going to talk about that a bit. And then we have what most likely interests you most here, which is point-of-care AI and operational AI, and I'm going to talk about these a bit. But if I have to kind of like summarize all of this and give 3 words, it's kind of like the title of my talk. It's prevent, predict, and personalize. That's kind of like the main overarching goals of all these different verticals. And I really like this quote. I think it's from Carl Deep, saying that a proper division of health AI at any health system should be to deploy research AI. So don't just develop models, but try to deploy them. But also figure out what's already deployed that you didn't even know, and try to research those and make sure that they're working the way they are. All right, so let's start with prevent and the point-of-care AI applications that we're working on. So a bunch of different people from the division are actively working on these, and in the grand pyramid, let's say, of like health AI tools, we're kind of like only at the top. So there's all these like new tools, and I'm pretty sure you know, and you're working on a lot of these different generative AI tools, clinical AI assistants. Now we have agentic AIs that becoming more and more relevant. But we're kind of focusing on the top of the pyramid, which is predictive AI, more traditional, let's say, machine learning applications to try to estimate clinical risk using all kinds of different data. And for that, one of our advantages, as I mentioned, is that we are a very, very large health system. And we treat around 2 million patients every year with over 5.5 million patient encounters. Only in the inpatient space, we can pull anywhere from like 700 to 1 million cases, encounters every year, right? So for most of our projects, data is not a problem, at least size of data. Quality of data is a completely different discussion, but at least size is never an issue for us. What's also good about our data is that New York is a very diverse place, as you most likely know. It's one of the most ethnically, socioeconomically, racially diverse populations in the US, if not the world. So anytime we develop all these AI tools, because of our size as well, we can start doing some proper sensitivity analysis across specific cohorts, just to make sure that our models and our solutions don't favor one group over another. So one of our main focus is in hospital deterioration. And that problem is, I don't think, only a problem of Northwell hospitals. In general, it has been reported that patients get under triaged or over triaged roughly in around like 15% of cases. What that means, especially for the under triage, is that people that should have been going to an ICU or some elevated care, they end up like at a regular medical surgical floor, and many of them actually deteriorate. And when we say deteriorate, it's one of 5 or 6 different things. So they either have an unplanned ICU transfer, they might require an RRT call, a rapid response team call, codes, whether like stroke, or you might need to intubate somebody, and unfortunately some people die. And that's, I like this quote from Dr. Patrick Brady that says, patients don't suddenly deteriorate, we suddenly notice. And that's not, of course, a knock to the clinicians, because they're doing the best they can, but a lot of the times these signs of deterioration that could be predictive are also quite subtle. And when a clinician has to care for a lot of different patients and has to go over like all these different data points, they would need a tool to actually summarize and detect and identify the subtle deterioration patterns to help them care for these patients better. And that's why we think AI ML can help on this space quite a lot. So we take a three-step approach to try to tackle this problem. So the first one is actually kind of counterintuitive, and it's to try to stop the unnecessary things that we often do in our hospitals. So we actually, this came from like looking at what's the main complaint from our patients. And the number one that kept on coming up was that you don't let us sleep during our stay at the hospital. Hospitals are notoriously the worst place to rest, although you should be so that you can get better. But because of a lot of different reasons, and mainly because of the fact that we are measuring vitals every 4 to 6 hours, around 2 to 3 a.m., a nurse will walk in, wake up the patient, measure heart rate, blood pressure, temperature, take vitals. So they will wake the patient up. Nurses don't like it, patients don't like it. We still do it out of an abundance of caution, but we thought, well, why don't we develop a tool, not to necessarily predict who's going to deteriorate, but flip it on its head and try to predict who's perfectly stable, and we can let them sleep and avoid that annoying vitals overnight. So we developed a tool. We used around, I think, 1.3 million hospitalizations for this, and we, back in 2020, we published this and showed that we can save up to 50% of these overnight wake-ups with like a very, very low risk threshold. So our false positives had to be 1 out of 10,000 at most, meaning that, because we are measuring this out of an abundance of caution, we want to make sure that like the threshold for when we are omitting a vital needs to be really, really low, meaning that we need to be absolutely certain. But even there, we can save more than 50% of these overnight sleep interruptions. And because of that, patients can sleep better. They actually, there are many studies that show that when they sleep better, lengths of stay decrease, of course, patient experience and the reviews out thereafter also improve. So that's step one. Step two, of course, is the opposite of that, right? So not who's stable, but who's at the risk of deteriorating. So prioritize attention to those who need it, and then and there again, it's a very straightforward deterioration prediction model using only electronic health record data. And these data are mainly the things that we measure across all our patients as soon as they hit the floor after admission. Right, so it's vitals, it's like very basic labs, it's demographics. This specific model was trained on around 1.6 million hospitalizations, and again, the combined outcome that we're trying to predict is deaths, ICU transfers, RRT calls. So we developed this model, and because of the size of the data set, what we found is that not only it's got very, very good calibration. Since this is a risk stratification model, we care a lot about the calibration of the model. So we want to make sure that when it says that somebody has like a 40% chance of deteriorating, that's actually reflected in the statistics of the model. But what's also interesting is that we recently, as a health system, moved to Epic. We used to be all scripts, and this took like 3 years, many billions of dollars, and essentially our whole IT, EDS infrastructure just not caring about anything other than the transition to Epic. So we went live in November for 6 hospitals, and then we'll have wave 2 now in April with another 12, and then the rest wave 3 at the end of the year. So because we were transitioning there, we were also looking at what Epic has in terms of tools. And there is the Epic Deterioration Index, which is most likely the most commonly used tool out there. So we tried to validate it retrospectively with our data. Epic was not very helpful to actually do this. So we actually didn't manage. We tried really hard to do this. and we couldn't. Like they wouldn't provide us any Docker image of these models or any other way to do this retrospectively. So we kind of like decided, and I'm going to go through that a bit later, to kind of look at, well, other people have done it because they turned this on, and so they have EPIC for many years, and they've looked at how this works retrospectively. So it turns out that the EPIC deterioration index is around 0.78 or 0.79 in terms of the ERC. Not really a lot of information about the calibration scores of these, at least from the studies that we found. Ours is around 0.9 in ERC, and then the calibration score is really, really good. So we feel that it's safe to say that it definitely outperforms every deterioration index. Again, not surprisingly, because we're training it on Northwell patients. So of course it will work better on our patients. What's important for us is that it performs consistently across all our hospitals, across different demographics. So there's not really one specific subpopulation that might not necessarily work. So we've embedded it into EPIC, so it's running right now from the first day of go live, but on the background, because we want to prospectively, silently validate it first, make sure that it works well, make sure that it works better than the EPIC deterioration index, and then the plan is to go live to all the EPIC hospitals of Northwell this summer. You have a question? Sorry.
Yeah, as part of the go live, what is the action that will get triggered as a result of this model?
So that great question. So this is supposed to replace our news scores, so the modified early warning scores, which people generally don't like that much. So I mean, it's a very low bar to beat to be better than news. But surprisingly, still it's the score that every clinician sees in the hospital setting, and the idea is to replace that. Those scores are tied to specific actions. So like ICU consult. What we also want to do here, and that's my next step, is we want to use this to also prioritize not just if somebody has like a higher score, call up the ICU, see if you can initiate a transfer. But also there are other things that you can do to just increase attention to the patient. Some of our hospitals have actually roaming teams of clinicians that kind of like focus a bit more on like high acuity patients. But also, the other thing that we could use is clinical wearables for some of these patients. The idea being that, when you're on a regular med-surg floor, not a tele unit, not a step-down ICU, or of course an ICU, your vitals get measured every 4 to 6 hours, right? So in between, a lot of things can happen. So for those high-risk patients, maybe what we should be doing is outfitting them with like these clinical wearables, which are not really high cost, and they record heart rate and breathing rate and temperature and movement and heart rate variability almost continuously. So we've been running several different pilots across all our hospitals with like various different devices, kind of like trying to figure out what's the device that works best, not only in terms of accuracy, but also for our clinicians, what do nurses like to use, what do patients tolerate. We tried these three different patches. We collected data from around 7,000 patients or 18,000 days of data collected, and the goal as part of a grant that we received as well is to expand this to 10,000 patients and around 25,000 patient days. That should be done by the end of the year. So by that time, I am not personally aware of any other clinical wearable data set of that size. The great thing about this is that we have all in hospital data for all these patients as well, all their outcomes, all their additional EHR related things that we usually capture, all their treatments, everything. So it's going to be an interesting data set to look at. What we already did with some of the data is to try to, of course, use these trends, use this continuous monitoring data and try to predict outcomes using both EHR or continuous monitoring clinical wearable data. So we recently last year published a paper on this where we show that you can actually build something relatively straightforward. It's not a really fancy transformer-based model. It's a kind of like old school LSTM-RNN. And the important thing here was for us was to validate it thoroughly, right? So we did a prospective validation, again silent. We didn't deploy this. It's not FDA approved by any means, not yet. So it was a prospective validation using patients that were outfitted on the same device with the one that the data were used to train the model. But we also wanted to see whether it's going to work on like a different device, right? So if we use patients that are outfitted with like a different wearable, like will it work, right? So long story short, it actually is agnostic to the wearable as long as the wearable measures the vitals at a specific amount of confidence and then accuracy. It's got a pretty good sensitivity for relatively decent specificity for these types of alerting algorithms, and the lead time for outcomes is on average around 17 hours, which according to our clinical collaborators is enough time to act upon and then be a bit more specific to, okay, this person really needs to go to an ICU. So that's another project that we've been working on. But again and again, what we keep hearing from a lot of like our clinicians is that that's great that you're telling me like somebody's going to deteriorate in like 22 hours or 24 hours. Thanks for that. I don't know what the hell I'm going to do. Yeah, unless I call up the ICU and they're going to tell me, yeah, good luck. So there is a component of not necessarily explainability of like why. I mean that's inherent, right? We do say for every prediction what's the main driving factors of why we're saying somebody's going to deteriorate, but also trying to understand the underlying physiology of what that drives our prediction. And that's where unsupervised phenotyping comes into place. At least that's how we try to tackle it. And really trying to find the clinical phenotypes of deterioration. Then there are many of them, right? People deteriorate for a lot of different reasons. So this is ongoing work. We published something on COVID where we found 4 different specific phenotypes. What's interesting about these phenotypes is that they did vary. They have different profiles, right, in terms of what's elevated or what's suppressed in the different clusters. But also because we had data across, pretty much the main phase of the pandemic, so like all 3 main waves, the 3 different variants, we try to see how these memberships in these different phenotypes change with the waves or with the variants. They do have very different, as you can see, prognosis, right, and survival curves. They do have also quite dynamic memberships when it comes to the different waves and the different variants. But also for us, it was important to be able to be dynamic in a sense that during the hospitalization, we don't expect a patient to start in a specific phenotype and just stay there, right? They could switch memberships even during hospitalization. So there is we also can follow this membership across hospitalizations as well. So the idea is for whoever we flag for a deterioration to also provide a why, right? I mean, at least what is the phenotype, what historically we've been doing to these types of patients, and what actually worked or not. One other project that was pretty interesting was we deployed these clinical wearables on women during labor. And the reason for that is one of the outcomes that we tried to predict using these wearables was maternal fever during labor, which is the single most important predictor of neonatal early onset of sepsis. So if we could predict the onset of fever hours ahead, there is a good chance that we could stave it off possibly. So we gathered data from from these patches from women during labor, including and very importantly heart rate variability. And there are specific reasons why heart rate variability, especially for fever, is strongly correlated. That's where a lot of like the autonomic neuroscience and physiology comes a bit handy here. But all this to say that this specific model predicts around 2 to 3 hours before a fever onset, essentially like the fever detected to go over 38, relatively well. And HRV is one of the most important predictors. So this was a collaboration with our neonatal clinic at our children's hospital. And you can kind of like see it, right? I mean, you don't need like a very complicated machine learning model. The blue is the curve of like the heart rate variability of women that did not develop any fever, and then the red one is the ones that did. 0 is the time that we identify fever onset, and you kind of like see these two heart rate variability traces. This is specifically RMSSD, kind of like start deviating around the 3 hour mark. So like around 2 to 3 hours, you can very safely identify the ones that will develop fever. Of course, all of these models that we're developing, we gotta be cognizant of like their performance drifts. You all know that all these models can experience performance drifts for a variety of different reasons. We've seen models start not working as advertised because of changing case mixes, new treatments emerging, new variants in terms of when it comes to like viral diseases. And then it's especially true when, of course, you create a model in a specific place and then you try to test it somewhere else. Or at another time where like a lot of things have changed. So, you know, we've all seen headlines about specifically EPIC models, kind of like having these issues. We've published on this, on non-EPIC, just published clinical decision support models that have been proposed for COVID. But as I mentioned, when we were transitioning to EPIC, we actually tried to be a bit more, since we couldn't validate these models ourselves with our own data, we're now starting finally, because we're of course running the EPIC in our hospitals, in some of our hospitals. But before that, we needed to find a signal of like what's going on and with all these different clinical decision support models. So EPIC has, I don't even know how many CDS tools right now, but we chose kind of the 5 models that we could see some of our clinicians wanting to turn on upon go live, and also the ones that had the most validation studies that were actually published. So we did this meta-analysis where we found 22 validation studies, 32 sites. It covers a significant amount of patients, around 3.2 million patients, and the 5 models that were validated were sepsis, mainly. That was, you know, most people really care about the sepsis model from EPIC, unplanned readmission, end of life no-show, and the deterioration index. So this is the bold number is what we found to be the real external validation AUROCs. The one in parentheses is what EPIC gives in their Galaxy page, right? So what they say that the model should work on, right? And no surprise there, there's a significant drop across all of them, some more than others. And EPIC is not shy about this, right? They do say that you need to localize your models, you need to retrain now. They say that. But regardless, I mean, we hope to publish this soon, because there's been so many different studies that have shown actually very variable results, right? But overall, there seems to be a drop in the performance of all of these models, right? So what to do about this? We actually had our own kind of like scare at Northwell when we developed a COVID-19 mortality prediction model. And because we were wave 1 in New York, we very quickly had tens of thousands of COVID-19 patients. About in April, I think we had like 30,000 already hospitalized, right? So we developed something really quick, and it seemed to be working great. So we started that, we actually deployed it, and it was the fastest deployed model I've ever seen before or after. They were very eager to use it, mainly for risk stratification. But but I was very stressed because we haven't really validated thoroughly prospectively. They just wanted to turn this on. We established like a monitoring pipeline just to make sure that this doesn't deviate. And what we started seeing is that although the ARC was relatively stable, around 0.75, 7.6, 7.7. What was important about this model was the calibration, right? So we looked at calibration metrics, specifically the integrated calibration index. And there, what we saw was that although like the red trace, it started to deviate quite quickly. That's mainly because during the pandemic, we had immense changes in the case mix early on. So people that were showing up in our hospitals in March and April were not the same ones as the ones in the summer. People were less afraid. They started to come out even if they're like not that sick. We also had our doctors treated differently. Vaccines came shortly after. So a lot of things started changing. If we weren't updating the model would have a very poor calibration. So we tried a bunch of different ways of trying to retrain. We essentially landed on a specific framework that enables these models to be self-monitoring and updating whenever it's needed. And when you do that, you can see that like the calibration kind of like stays at a pretty consistently low error rate. And that's important for us, and that's kind of like what we work and use in most of our models right now. All right, I'm going to switch gears to talk about operational AI. So we talked about kind of like clinical facing, clinical decision support tools. As I mentioned, we've been asked to also help out the health system on some nagging problems that have a surprisingly large cost and impact to the way that we're delivering care. So one of the first things that was asked of us was to help out with nursing shortages and nurse burnout. And one of the things after meeting with nursing leadership and the representatives of the nurses, they told us that, yeah, we don't want any more questionnaires about our burnout, please. But if you can right size our units, that would be most likely the most impactful thing. So we started thinking of, well, how are we going to right size the units? I mean, the main problem is that nurses quit all the time, and there are shortages, I'm pretty sure not only in New York. And the ones that are left behind have to work more, so they do get burned out quicker, and this is like a pretty important problem. And you can see in surveys that talk about how long are they going to stay in this profession, or whether they believe they experience shortages. And this global problem really, but mainly focused on the US, was exacerbated by the COVID pandemic, of course, but it has this cycle of nurses that get burnt out, quit, the ones that are left behind get burnt out easier. We actually saw that we have like these well-being surveys administered across, I think, 20 or 30,000 nurses that work in our hospitals, and we see like a significant correlation between reported burnout, this is self-reported, and also and the attrition in each unit, right? So the average burnout being reported and attrition. So we see all these numbers, and we're like, well, okay, what happens when a nurse decides to quit? The current state, or until recently, was that we're reactive to this, right? The nurse leaves, and then the nurse manager says, oh, I have a vacancy, so I need to hire a new person. So they go to procurement, then they post the position, then they get applications, then they do the interviews, then they choose the person, they put out offer letters. If they accept, they have to be onboarded, trained. That's usually at least 6 months to most likely a year. When you've had a nurse, you don't have them anymore, and until you have a nurse that is ready to hit the ground and work, it takes months and months. So during that time, of course, patients still come. So what do? Well, we use flex staff, right? We use temp nurses, and because it's an easy fix, it's used a lot in our hospital health system. The problem is that it's not the optimal solution because it costs double on average, and also our regular full-time nurses don't necessarily like working with flex nurses that much, at least in New York. They have to train them all the time. We have a lot of union hospitals, so they are the ones that are called upon when strikes happen, and they do happen in New York. So for all these reasons, the most straightforward way to try to tackle this problem was to try to reduce flex staff utilization. So how to do that? Well, the only way that we could think of was to try to forecast both the nurse attrition and the demand, because it's you can't just solve this problem by estimating how many nurses you're going to lose. Okay, that's how many nurses you should be hiring, because demand also fluctuates. So that's the idea. The idea is to develop a model that predicts demand in 6 months or a year in every single of our units, and also predict the attrition of the current workforce, full-time workforce on those units. Combine those, suggest the hiring needs right now, so that when you start the process right now, although you know that you don't see it, when they are ready to be to work, that's when you're going to need them, and that's what they're going to hit the ground. Now, in order to achieve that, we developed we actually modified an AI model that actually Amazon uses to predict sales of certain types of merchandise. So it's deep AR, it's a deep neural network based autoregressive model. Nothing super fancy about it, but it has some really cool properties. You don't need to train individual models for different specialties, because of course different specialties have completely different dynamics, both in terms of their seasonal effects, but also in their attrition rates. So you fit one, and it can work better actually than specialized models for each of these specialties or units. And I mean, the model takes HR data mainly, how many hours each nurse works, demographic data that we have for all our nurses, role-related data, their tenure, whether they're union or not, their level, and then job-related data. These are the HR data, how many sick hours they requested, how much overtime they worked, hospital distance from home, things that you would expect might play a role a bit in like a decision for a nurse to leave, either to quit altogether nursing or to leave our Northwell and go to another health system. And New York has a lot of health systems, so it's not an easy market to keep your nurses. They can shop around. So we developed this model, and then the question was, well, how do we convince our HR, our finance, our nursing leaders to use it? We told them, he has a great RMSC. And they were like, I don't even know what you're talking about. So then we're like, okay, let's talk dollars, because I think you understand that. So we estimated the past year how much money could the hospital or the health system save if they were following our advice. And sometimes our advice is not that great, right? We might be suggesting more than needed, and they end up overhiring, right? Or underhiring. When we're overhiring, we don't assume that we're going to fire them right after. So that's a mistake you don't want to necessarily make. Underhiring, of course, is inherent to do because you can't hire for like peaks. So you will use flex staff. We're not saying that we're going to get rid of flex staff 100%, but we can first of all reduce that utilization. The second thing that we could do is we can actually predict and try to get better rates if you book this flex staff in advance, right? And reduce overtime usage as well. All this to say that when we run simulations to actually see what are the cost savings that could be realized from this, in only 10 out of our more than 400 units in our hospitals, and now this number actually is more than 500 because we didn't run it on new ones on the Connecticut hospitals. It was around $10 million a year, right? And that's only 10 units. Our nursing budget is over, well, $2 billion a year. That was 3 years ago, so I have to update my numbers. So it's a very significant amount of cost for a health system. Anything you do that moves the needle, even by 1%, it ends up in ROI of tens of millions of dollars, right? So this is something when they asked us, I was like, forecasting nurse attrition, like, I don't know if I care about it that much. And then when we started thinking of like the potential ROI, it became one of the main things that we wanted to work on, mostly because all of a sudden you start showing impact. And it's not only dollars, right? I mean, when you have happier nurses, you get better care. They don't waste time trying to train flex. Yes?
How did the nurses respond to aid all their data being put into this model?
They asked for it. So I'll tell you, first of all, this was nurse driven. So we proposed like 5 or 10 different solutions and they asked for this, right? But the selling point is that we're going to right size you. This could eventually, like, if all these cost savings, Northwell is a non-for-profit, right? So all these cost savings could roll back to like increases in their salary too, right? I mean, having them happier. And the other thing is that this is not a tool that will identify the individual nurse that's going to leave, right, and maybe punish them. We actually have to stress that out strongly. This is a tool that estimates for units numbers, right? So we don't know who's going to leave. We could potentially, but we don't want to. It's actually against New York State law. Well, it's not against, but if you build something like that, then you have New York State actually provide some oversight to your tool, which that was not the goal of this, right? The goal is to provide like numbers.
Population level.
Yeah.
We have some questions online. Do you want to take them now, or do you want to like cover more stuff? Because this is what I think is very interesting.
Yeah, I'm just going to have one more slide here, and then I'm going to take questions. And the other selling point here is that these models can identify the numbers, but we can also try to figure out, again, type of the phenotyping approach, the different phenotypes of nurse attrition, and try to figure out whether there are any modifiable factors in some of these clusters. And that RHR really like this because they wanted to figure out novel or new or like what are the intervention strategies to avert nurses from leaving they should be focusing on, right? So that's also work in progress. All right, I'm going to stop here. I have like a whole other thing, but I think we should about bioelectronic medicine. This is like a curveball, kind of like bringing you back to my roots, but I don't think we have time for this. I want to make sure
we'll cover it the next time. We'll do it for the next session. Great. Well, first let's thank Dr. We do have some questions online. I expect a lot is going to back up some of this nursing one, but anybody in the room in the meantime want to jump in?
John, I have a question.
Go for it.
Thank you. Fantastic presentation and so innovative and amazing. So thank you for that. I noticed that the first part of the talk, you were talking more about identifying, doing like predictive modeling for clinicians, which typically ends up identifying more problems. And therefore there is always a resistance. And the second part of the talk was more solution oriented, right? Mm-hmm. Like workflow. Could you like comment on that dichotomy, please?
Yeah, so for our clinical facing models, everything that we work on is stemmed from, I mean, that's why I really want for our division to have clinicians that are actively seeing patients, and also we have a direct line to clinician leadership to make sure that we capture like the whole health system, let's say, priorities, right? Whatever we're working on, in principle, should be adopted immediately because they are the ones asking for it. It's not like we decided, oh, we're going to build a deterioration model. Here's why. Well, for years we've been hearing that like news sucks. We really hate it. It's like annoying that pop up, all that, right? So I think the way that we built these models, but right now, and they're running in the background with what we thought, how we thought we should present them, but right now we have a whole clinical transformation team that we're collaborating with that are the boots on the ground that are not going to just tell us this is how this should look like. These are the immediate, the different arm of all your predictions, right, or all of the levels of the predictions, but also they will, the great thing about it is that they have people in each of the units that we're either going to pilot or just go live and train people, right? And they've done that with some external tools, so they learn from the hard way. So I'm feeling confident that, I'm pretty sure we're going to find like a million different problems. I can tell you some horror stories of like previous deployments. For the operational tools, it's actually a bit easier because these people already, they don't see patients and they sit in front of a computer, so they are keen a lot of the times on forecasting models, and they would use this a bit easier. What's the main barrier there is bringing together finance, HR, and nursing managers, convincing finance that they should front load the budget and let open up these positions, even if like right now that unit seems well staffed, and also letting them know that you're going to see the benefit of this, the ROI kick in a year later. You're not going to see it now. It's not going to be like turn on, I'm all of a sudden saving money. I'm actually losing money in the beginning to save more later on, right? So there is, that's a bit of a barrier that we've noticed, and a lot of discussions there. But from our side, the division is mainly focused to develop and work with like clinical transformation and other partners to develop correct models. The way they're used, as much as I would love to be part of this, is not really my expertise, right? So we need the clinical transformation people to help us out, because this change as well, like how doctors use it and see these, and also what we've also found, one last point, nurse-doctor communication also is extremely important in this type of like clinical facing tools. We've been piloting an external sepsis prediction model, which has been shown to work really well, even through RCTs. And we found that the nurse-doctor communication was the main barrier of actually being used. It had very low adherence rates. So anyway, there's a lot of things that we're figuring out as we're deploying these. But our focus is a bit more about developing the right models and making sure they work well.
Okay, so someone asked me to go back to the model pipeline slide, and then maybe we'll take a question over here. I could imagine you certainly need the clinical transformation arm, but they clearly need you too, right? Like a lot of forecasting demand. Shouldn't that be relatively straightforward? They must have done something before. What was their baseline?
Their baseline is like human forecasting. You'll be surprised, but like that's really the way that we actually, there are some finance people that are supposed to be amazing at forecasting.
Yeah, that's like a whole field of business analytics.
But this is, again, there are some tools out there, but they're more about forecasting how I'm going to schedule nurses in the next week or two. And you have a lot of like companies that propose solutions kind of like that, but not exactly like this. As far as we know, so like Palantir at a certain point reached out, and there was like some discussions with Northwell about developing the nurse scheduling tools and forecasting there. We didn't see something like that. We actually looked, I mean, if somebody would build this, they wouldn't even publish this too. So there weren't really a lot of like publications on this space as well. So we decided, oh well, you know what, we're just going to build this. So
Let me take this question.
Another question. Thank you. This was a great lecture, and I have a lot of questions, but I'm going to focus on one. Northwell is an integrated healthcare system. What advice do you have for us at Stanford? Since it's not a truly integrated healthcare system. There's a lot of people doing a lot of great work, but it's more spread out. So.
yeah, I mean, we say we're integrated.
28 hospitals.
Yeah, it's also how this was built, right? So like Northwell used to be called North Shore LIJ, and that's because you had the North Shore University Hospital and the Long Island Jewish Hospital that were in a distance of like 3 miles from each other, and they were for decades just fighting each other over like the same pool of patients. And at a certain point, I don't know who, but they decided, well, instead of fighting, why don't we just join forces? And so that started, I should know this, but anyway, some decades ago. But then they started essentially buying hospitals that were struggling and then reforming them under the umbrella of one health system. And they grew from literally 2 to 28 now, right? Now, that's great, but what that expansion, that's not building new hospitals based on what you want, but acquiring already existing hospitals, comes with a lot of baggage, right? And a lot of local fiefdoms and people saying, we do this way. So these problems exist in Northwell as well. I mean, I don't want to think about all the different criteria for an ICU transfer, or the different criteria for an RRT call across all our hospitals. Before we transitioned to Epic, out of our 23 hospitals, because the new ones are new, 13 had the same EHR. The other 10 had their own custom-made EHR. So there's a lot of like issues that we've faced. In terms of advice, I don't know if I'm the right person to ask for advice here. We try to work with the people that wanted to be part of like a central, let's say, unifying way of doing things. For us, what really works is it's word of mouth in a lot of cases here. If you have like leadership trying to impose these models and say it's not going to work, they're going to find a way around it. But it was like piloted in one place, and then showing, like meeting with like the leaders of other places and saying like, look how, don't you want to be part of this like new wave?
Yeah, no, that's helpful.
Yeah.
Thank you. Appreciate that.
Let me try to squeeze in a couple questions online. We're going to cut off the session soon, but hopefully people in person can approach directly. Online, Simon Chen, do you want to ask your question? And then maybe Abby can squeeze it right after that. Simon, do you want to do it?
Nice talk. Really fascinated by the HR application, the attrition forecasting. Do you foresee the possibility of like nurses or employees starting to adversarially and try to mess up the prediction? Or do you think predictors are robust enough, like demographics or union status, those are kind of immutable things?
That's a great. If we can get such smart people to start messing up this algorithm, they figure out reverse engineering and start messing it up, I think we're in a good place. I would say this algorithm, the purpose of this algorithm is to become obsolete after some years of being used, right? Most likely, this algorithm will be successful if people don't use it anymore, right? But at first, they really need to believe in it and use it, even if they say, no way, or why should I do this? What's actually interesting is that, again, there are different stakeholders here, people that are that need to all come together and agree on using this. finance is the hardest one to budge. But the HR, nurse managers love this. Like all the CNIOs across all our hospitals, they calling me, okay, you know, can we turn this on today, like in our hospital? The problem is that you can't just turn it on whenever you want. There's millions of dollars at stake, so like there's a lot of like hoops you need to go through. But yeah, like reverse engineering, and I don't know to what would be the goal of hacking this. Let's just say to hire more and more nurses. I don't know. Like a nurse manager would want to. They all want to hire more nurses because they are short-staffed. This is the purpose of this. But as soon as you're properly staffed, why would you want to manage more people? And to that, actually, the reason why I'm not afraid that people are just going to overhire is because when you overhire, of course, overtime drops, right? There's a U-shaped relationship between overtime and whether somebody's going to leave or not. If they work too little overtime, they're going to leave. If they work too much overtime, they're going to leave. You got to find that sweet spot, of course. For an individual, you can't, but in general, being proper stuff helps. I don't know if that answered your question.
That's great. I think Abby said I think she's going to meet with you individually in another half hour, right? But was there one more question in the room? Otherwise, we'll close the official session. Go ahead. We'll have the last comment from one of our postdocs.
Thank you so much for this great words. My question is related to mostly develop and get all the models in hospitals. For example, in Stanford, the data that are available for research is sometimes completely different in terms of format and in terms of the data model that we use, different from the hospital. And so, what kind of challenge you have dealing with this, and how do you deal with data?
Yeah. So the data we use from the AMR for all these models were coming from our old EHR. And they were reflective of the actual data that are captured in the HR. So they don't have a different data model. We actually, for this reason, did not convert it to OMOP, which is a bit of a mistake, but at least for us, it would make the deployment a bit easier. Now that we're moving to Epic, it's exactly what you say. The data we've been used to working with forever now need to be mapped into Epic, and it's a big lift. I mean, the short answer is you just have to have dedicated people to do this work. It's painstaking, but it can be done if you have proper clinical informatics data engineers that know how to transform your data from one system to the other. Now, for a lot of the work that we're doing, because these are real-time systems, you need access to real-time data marks, updating constantly. That was a 2-year fight that I had with our IT on get to the access to that data set. So, you know, some things they're there, but somehow you can't get access to. Some things you gotta just focus on figuring out the mappings so that you can deploy them. And then, even if you figure out the mappings, deploy them, and then you're gonna figure out another 100 problems that you're gonna have to iron out. That's why, you know, I've included a 9-month runway between when we develop the model and when we're going to go live, because I wanted those, you know, it took us 3 to 4 months to even map out the deterioration model to Epic. Then it took us about a month to actually embed it into Epic. And then it took 3 months to troubleshoot it while it's running silently on Epic. And now we're going to start silently validating it. We're going to use 4 to 6 months of silent validation. The good news is that we're already getting millions of inference points for this, so it should be, we're well powered to do so, and then go live, and then go through the committees actually.
Only
because there's a lot of committees to go through.
This is basically obviously a lot more we should follow up on. We're past the time. We clearly could talk for another hour, and we should another time. Time over our hand for Professor Zanos.